Hi, I'm Ron Gagne, the director of the Harvey Lab here at AUC. And today we're going to have a brief little presentation as an example of how we start teaching medical students in the second semester about doing the physical exam and improve their listening skills on Harvey Lab. So this is Harvey, and our patient is from the islands here. As you can see, he's wearing sunglasses. And when we do a Harvey examination, the first thing is inspection or observational skills. So we have carefully is what we're going to do. We're going to do inspection, palpation, and auscultation. 3 of the 4 major elements of physical examination. The 4th one, percussion. We don't have to do percussion for examinations. You can do percussion like in neonates to see the size of the heart, but for adults, normal adults, etc. Now our Harvey here has blood pressure. We measure JVP with this. We measured a radial pulse, and you can see the radial pulse for observation from a distance with this thing. Okay? Because it's important to have radial pulse examination during cardiac so you can tell what's S1 and S2. We'll be talking about that later on. Okay? And this here, of course, this cup here is to highlight the exaggeration of the respirations. Okay? Okay? So, inspiration, expiration. Inspiration and expiration. So your observational skills for the first part of inspection then have to do with observing respirations. And now I'll show you what we need to do for the beginning of the cardiac exam. Well, the first thing is you look at the respiration to see if you can observe them. Then you turn your attention to inspection for the JVP, which you'll be exposed to. This is short for jugular venous pulse. The JVP is always measured on the right-hand side of the patient. Okay, and you look for pulsation that is kind of like a double pulsation like this, okay, during diastole. But you can't tell if it's diastole unless you put your hand on the pulse to see if the pulsation you see in the neck here is either carotid pulse, which is usually up there, or JVP in a normal, sometimes is not visible in the neck in a normal person, but sometimes can be visible just in the lower part of the neck where the jugular vein, external jugular, is visible. Okay? So when we look carefully then, we look and finally see the JVP, which is, and you point to it, the top of it is roughly right about there. On this side, it'd be right about there, over here, okay? You gotta be careful to distinguish it between the carotid pulse that can be transmitted. But the carotid pulse will be the same as the radial pulse, okay? Same timing. The radial pulse being right there, okay? Okay, so the first thing you do is JVP, and then you turn your attention to observing for any kind of heaves in the precordium, okay? And first you go and you inspect carefully. Looking at it laterally is the best way to go. So you look at it laterally and look for a heave in the second right intercostal space, second left intercostal space, a heave along the left sternal border, particularly at the 4th intercostal space on the left along the sternal border, and look for, while your hand is on the pulse, for the PMI. I see it. I don't know if you guys can see it, but it's right there. And you point to it like that, okay? All right, so that's the inspection part of the cardiac. Respirations, feel, look for JVP, and look for heaves. Heaves are one of the chambers in the heart is abnormally large and pushes against the chest wall, and it's actually, if you pay attention, it actually raises the chest wall in those various 4 areas that I showed you, okay? So now we're going to feel for heaves with our hands, okay? Now, first you put it over the second right intercostal space, right there, and wrap it around to the second left, feeling the entire part of hand. How do you know if that's the second right or the second left intercostal space? Most students don't know where that is. Okay, so how do you feel that? You feel the carotid, the clavicle, the first indentation below the clavicle, okay, is the first intercostal space. The intercostal space is below the rib that you're naming it, okay? And then you go over, you feel, okay, over the next rib, and the second space there is the second intercostal space along the sternal border, right there. That's a listening post. Do you know what that listening post is called also? He'll go over that with you, okay? It's called the aortic listening post. But I want you to name it as the second right intercostal space is where you hear your first listening post. Okay, so you feel there for a heave, go across, right straight across, of course, is the second left intercostal space. Okay, you feel there for a heave, no heave. A couple of other things here. If you have a thrill, a vibratory sense along these areas, that would be called a thrill. Okay? A thrill comes from an a very loud heart murmur. We'll go over those details throughout the rest of this course here. But a murmur, as you know from Dr. Hammerl, you're going to get a little lecture on that later this week about her murmurs, are, flow across an abnormal valve or defect in the heart. Okay. So, okay, heaves or thrills. No, I feel no heaves and no thrills here. And then I'm going to turn along the sternal border, the length of my hand here, underneath the hand here, and feel for heaves along the sternal border here. And thrills. By different chambers of the heart have thrills depending on where they transmit, and we're going to, great guy here, Mike, our tutor, is going to teach you all that over the next hour, okay? And finally, you just turn around like this and go laterally, okay? In mid-clavicular line usually, in the 5th intercostal space, okay, mid-clavicular line, 5th intercostal space is where the PMI is usually found. And now, do I feel a thrill here? No. The PMI is short for point of maximal impulse. It's where the apex hits the chest wall with every beat. PMI. It's a special kind of heave. It's a normal heave. Okay? PMI is normally palpated there, only about half the time. Sometimes you can see it, sometimes you can palpate it. If you can't palpate it, you have them roll over on the left side to see if you can palpate it. Okay? So that's the last part of the palpation is the PMI. And sure enough, what I want you to do, whenever you feel a PMI, as a student, and until you're completely used to the whole thing after you've done thousands, you always point to where it is and see exactly and measure exactly where it is. Mid-clavicular line, which is usually medial to the nipple a little bit, and then you count your spaces. 2, 3, 4, 5. Oh, okay, it's 5. Okay? All right. That's it on the palpation. Okay, what's the last element?
Auscultation.
Auscultation. The stethoscope. Know your equipment. Okay? There's a diaphragm and a bell. You have to turn this to hear the diaphragm and the bell. okay? Not all of you have the same equipment, but know your equipment. There's a leaflet with your equipment. You're gonna be using it on yourselves today to hear your own sounds. But, okay, so we always start with the diaphragm and try to do the same thing all the time. So you put the ears pointing forward like that. Then test your equipment, okay? And then you're going to listen. So first you go to the second right intercostal space, okay? And you listen. And you do three things. You identify what's S1. If you don't know what S1 is, you put your hand on the radial pulse, and it's usually associated with S1, the pulse is. I say associated, it's not exactly at the same time. For you guys, when you're going to be listening with these scopes here, you're going to be listening there, okay? Okay, so I hear it. Now I say, okay, that's S1. Then I ask myself, which one is louder, S1 or S2? Ah, S2 is louder. That's normal here. You'll note that this is normal. Okay, and next is what's in between. Any noises in between? None. Okay, so then I go to the left, second left, okay? And I see S1, S2 is louder, and now I ask myself, because this is the listening post where the pulmonary valve is the loudest in closing, is S2 physiologically split? You guys will learn about splitting later, but physiologically split means that I hear a double sound for S2 on inspiration, okay? That's splitting. And yes, I do. S2 is louder, S2 is physiologically split. That's all I need to know. Then I go to the fourth. Whoops. I still have my hand on the pulse. Whoops. S1 is louder than S2 here. Is that normal? Yes. You'll learn about that too. What about S2? S2 isn't as loud as S1, but I'll be darned, S2 has a double sound. That's a particular situation. You'll be explained to that during the course. Okay, that's normal. And finally, I go to where I pointed on the PMI, the last listening post, with the diaphragm, and I listen, and I listen, and I listen. Here, I hear S1 and S2. S1 is louder, and wouldn't you know, right after S2, there's another sound. So that must be labeled sound 3, S3. Son of a gun. Is that normal? Well, you're going to learn that it is in some situations. And in this case that I have, it is. Okay? Now, the last thing is to hear an S3 better, or a fourth heart sound better, you only can hear third and fourth heart sounds only at the PMI and in the fourth left intercostal space, okay? Only. And it's best heard with the bell, okay? So at the last part of the examination, you're going to listen with the bell here for an S3 or an S4, and sure enough, I hear that S3, like I told you. You'll learn more about it. And here, I don't hear an S3 or an S4. And for Harvey's purposes, okay, that's the entire examination of cardiac. Now, you will be spending the rest of this hour learning the skill of really listening, what I just told you about. Because your mind plays tricks on you. follow the steps that I just told you in listening at each listening post, and see if you can match that with, along with Mike here. Okay? Thank you very much. Thank you.